So I want to bring you back in time, reeling in the years. As you will all know, HIV, or AIDS really, was described first in the late 1970s. And in the early 80s, it was slowly accepted that it was possible that it was the transmission of an AIDS agent from mother to child that accounted for a new immunodeficiency in children. The 80s actually were a very bleak time. It was very grim. People were dying. Young people, previously healthy, were dying from AIDS. There was a lot of anger because as medics we didn't have the answer. There was a spark of hope in terms of the repurposing of a drug, AZT, now called azidothymidine, which seemed to have some impact in reducing the risk of opportunistic infection, at least in the short term. But it didn't last for long, and it was associated with significant toxicity. For children, not much was happening except that they were getting it and they were dying. But even for those who didn't die, they were shunned from schools, their homes at times were burned, and it really was a very bleak time. So in that setting, in the US, in the late 80s, the National Institute of Child Health expected AIDS to become the 5th leading cause of death for those 1 to 24 years. In Europe, the number of AIDS cases was growing, and globally, AIDS was really stalking the ground. Women were getting it, were dying. It wasn't just children who were being infected, it was children who were losing their parents. So it was really what could be done. So in that context, a group of pediatricians and obstetric investigators talking together, gathering together bits of information in terms of evolving science, thought that perhaps they could use azidothymidine to prevent transmission from mother to infant. It was a hugely controversial move. There were genuine concerns because there was the toxicity that was recognized in adults. There was also the history. There was the history, the shadow of thalidomide, and people were afraid to do anything to intervene medically with parents. There was the history of diethylstilbestrol. And there was also misinformation, and you're all familiar with that from COVID, the dissemination of misinformation that HIV wasn't the cause of AIDS, that it really was a lifestyle disease. But on the other side, there was what was happening to children, and 10% of them with rapidly progressive disease dying in the first year of life, and the median survival was just 9 years of age. What they knew at the time was they knew that most transmissions seemed to occur either late in pregnancy or labour and delivery, that there were animal models that suggested that azidothymidine could interrupt transmission, and they had some early phase 1 studies in terms of pharmacokinetics and a small amount of observational data. And so they planned this study, the PACTG 076 regimen, which was to target multiple time points, a little bit blunderbuss because we didn't know at what stage. And I do recall sitting in the room with the investigators as a young trainee and listening to them debate the pros and cons of doing this and the personal negative downside to becoming involved in doing a trial like this. So they were going to give azidothymidine during pregnancy, at delivery, and for the first 6 weeks after life. And many of you will be familiar, and those who aren't should really look back on this study because there is so much to learn from it. Multiple investigators, it took collaboration. It took many sites, both in the US and Europe, in France. And it was a randomized, double-blind, placebo-controlled trial of HIV-infected women, 14 to 34 weeks gestation, avoiding the first trimester, women with CD4 counts above 200, because at that time, treatment wasn't indicated for their own needs. And it ran from April 1991 through December, at which stage the DSMB intervened because, to everybody's surprise, there were great results. In terms of as a trial, randomized double-blind controlled trial, the groups were well matched, both in the mothers in terms of their age, their CD4 counts, their underlying demographics. So it was a well thought out, well conducted study. There were 477 women enrolled, 409 who actually had started on the treatment, median age 25, and the outcome at that stage was known for 180 who had received azidothymidine and 183 who had received placebo. And the difference was dramatic in that there was a 67% reduction in transmission risk to the infants of those who had received zidovudin, with transmission rate 25% in the zidovudin arm and 8.3%, and this is shown graphically here. And that was the first demonstration of treatment as prevention in terms of HIV infection, and something that we are still thinking about in the concept of other diseases, be it whether now we might be able to intervene with diseases like hepatitis C to prevent even any transmission there or others. Why did I choose this study? Because of, to me, the bravery of the investigators, because they critically analysed what had gone before. They used the data that was there to really come up with a good trial design, and they did it because they wanted to do what was right for the children in the face of a lot of social hostility. They challenged the existing dogma that you shouldn't be intervening or giving any medication to women who were pregnant. They reached out, and there was true collaboration, which was difficult. It was the first demonstration of treatment as prevention, and it was beneficially life-altering for many children and for their families globally. It paved the way. It wasn't the ultimate answer, but my goodness, it really turned the tide. And since then, the numerous studies have gone to the point where now we really do not expect a woman who is treated in pregnancy to have an infected child. And so therefore we can hope for the elimination of HIV in children. Beyond that, it changed attitude towards antenatal intervention as prevention, and thus it gives us lessons for today. And you can see graphically the impact there within the US in terms of the introduction of this. It was very rapidly introduced, and the decline in the rates of perinatal HIV infection. It also had a wider impact in terms of the recognition of the benefits of identification of those who are HIV infected for their own good, as well as for example, the prevention of transmission. And as I said, it has allowed us hope for elimination. Initially, WHO had set that goal for 2015, and that was missed. It has now been recalibrated, first to 2020 and now to 2030. But there is good news, and in December 2021, Botswana reached a key milestone in the elimination of mother-to-child transmission of HIV, meeting the target of transmission rates less than 5%. So there has been a lot done, but there is a lot more to do. As of June 2020, 82 countries had a national plan for the elimination of mother-to-child transmission of HIV. 85% of pregnant women are estimated by the World Health Organization to receive ARVs in pregnancy. But reality check, 100,000 to 240,000 children acquired HIV in 2020. More updated statistics are not available because of COVID, but now as we resume our lives, we cannot let these goals fall behind. Thank you very much.